Thanks for inviting me. Um, so I have 45 minutes and some questions, right? 2 hours. Okay. I have nothing to disclose relevant to this talk. Just wanted to go over a few terminologies that we are going to talk about, and I think it's important. Most of what we are talking about is not related to brain oxygenation monitoring, um, and I will explain why, because it's not very important. So what is monitoring? Is to observe and check the progress or quality of something over a period of time. I have a mic. I don't know. What should I do? Just it's working. Okay. Yeah. So you monitor and you observe something over time and see what happens to that. So that's monitoring. That's important to know because a lot of the stuff we do are not fitting into this paradigm. So we're not following something or we're not doing it over a period of time. And so, for example, for PBO2 monitoring, you probably have noted that many times when we walk into a room, ask if we can connect the probe to a Moberg monitor because that gives us an idea over time. And without that, we really do not, fulfill the criteria of monitoring. We just see things in snapshots. And first important thing is realize what we are monitoring. What is the nature of the thing? Some stuff that we monitor are by themselves a physiological or pathological entity. For example, blood pressure is a thing by itself. We can monitor it, or heart rate, or temperature, or O2 sat. But a lot of the stuff that we monitor, including some of these things, are surrogates for other physiological or pathological entities. So, for example, blood pressure can be monitored by itself as a physiological entity, but it can be used as a surrogate for organ perfusion. And this is an important distinction because if you follow a physiological entity and you change it, you have changed that. But if you follow it as a surrogate, changing that will not necessarily change the thing that you're looking for because it's only a surrogate. It's not necessarily the same thing. Or you can use heart rate as a surrogate for pain. We sometimes do that if the situation is tachycardic, but are there any other reasons to have tachycardia? Yes. Or O2 saturation as a surrogate for tissue oxygenation. And it's just a vague measure for that, for example. Or we use TCD as a surrogate for vasospasm. I hear frequently say patient does not have vasospasm because TCD is normal. That cannot be true. It's not also wrong, but they're two different things. You're using TCD velocities as a surrogate. All you can say is that velocities are not high. Maybe there's not vasospasm. Or we use CPP, something that we can measure at bedside, as a surrogate for CBF, or cerebral blood flow, something that we have difficulty measuring at bedside. And they're not necessarily the same thing, and you may remember a curve shape thing that they are sometimes similar, but at the extremes, they diverge from each other. The next important thing about monitoring is that how we are monitoring, and a few things come to mind. One of my factors is accuracy. Some of the stuff we can monitor with different accuracies based on different methodologies. So blood pressure by cough versus A-line, there's difference in accuracy with them. We can measure cardiac output by multiple measures. We can use a pulmonary artery catheter, which is still the gold standard. We can use an echo. It's an ultrasound-based technique, so technician dependent, or we can use Vigileo. Probably none of them are perfect, but pulmonary artery catheter is way superior to Vigileo and more accurate. We can measure ICP by EVD versus Bolt, and many times you see that they do not necessarily correlate, and EVD is more accurate. Other factor is reliability, which may not necessarily be the same as accuracy. Reliability means that if you measure something at different times, and if it remains stable by itself, you should detect the same value for it. So it will not be variability in different measurements by different interpreter people. For example, CVP is kind of unreliable measure. You check CVP 5 minutes apart from each other, you get very different numbers from each other. That's why many times we do not like to follow CVP. CVP of 4 and 12 is not that meaningful. While blood pressure of 180 that has been sustained for some time, it is meaningful. And a lot of ultrasound-based methodologies, almost all of them have a reliability issue. We have two techs come and examine the same stable patient over 2 days with TCD, and they get numbers that are like 200% different from each other. There's nothing wrong with the machine or either of the techs. It's just an ultrasound-based technique. Or, for example, you can use TCD, which has more reliability. If you do two CTAs on a patient back to back, you're getting the same values. Well, it may not be as accurate as an angiogram, but it's very reliable. Or catheter angiography is both accurate and reliable. And then the next factor is invasiveness. Of course, we prefer to use something less invasive, and we try to remove invasive devices. So many times, for example, on the floor, we check blood pressure by cuff versus A-line. So we sacrifice accuracy and reliability over time for invasiveness. We can measure cardiac output by pulmonary artery catheter, but that's invasive. So many times we decide to choose a Vigileo and buy it. If the patient is a candidate for heart transplantation, we may have to pay that price. But if the patient is under induced hypertension for vasospasm, probably Vigileo will do the job for us. Or you can check vasospasm by CT angiography and catheter angiography. And both of them are in a way invasive, but definitely catheter angiography is more invasive. And then the next factor is cost. TCD is much cheaper than CTA. And cost is not only money, but it's also irradiation. It's the cost to human body. Or head CT is cheaper than MRI and also saves 45 minutes of time of personnel standing in MRI suite. And the last important thing is how we use the monitoring data. There are some entities we measure, but we cannot really change them much. And there are some entities that we can measure and we can change a lot. So for example, we most of the time can manage blood pressure, except for extremes. We typically can manage intracranial pressure, but probably with more difficulty than blood pressure. We can induce burst suppression, but many times it takes a lot of medication and other complications with it. And we have a hard time bringing down ammonia in a patient with liver failure. So sometimes we have to think, I'm measuring something, can I change it? And if not, why am I really measuring? Just looking at the number is not going to help. And does the change alter clinical outcome? That's another important thing. Like, I can decrease blood pressure, and probably that will decrease the risk of hemorrhage. I can also decrease blood pressure, but I'm not sure if that will change the outcome of a stroke patient. So it's not only what factor, is it a surrogate, can I change it, but also doesn't change anything to change it. So if you are on a medical ICU, you hear that they don't like to chase ammonia levels. Once it's high, it's established, you don't follow it, you do the treatment for it. Because that does not correlate with outcome by itself. And it's misleading, can go up and down, and you can do things that are not necessarily implicated at that time. So let's think of this example. So Hailey lives in a very rural area. She has access only to one grocery store. It's a small. It's more like a gas station store, and they have typically like, I don't know, 2 bags of flour. And she makes this amazing tart, which strangely none of us have tried, but all family members know about it. So 99% of the time, Haley can make that tart. Not for us, but for those family members. So it seems that the chain of events and factors implied in this are working majority of the time. The flour factory has enough supply of it. It has the trucks to go to roads that are open and bring it to that store. They stock it. She can buy a bag of flour, and she can use it also to cook. So, but if you think about the different parts of this chain, there are a lot that can go wrong. Again, most of the time things go well, but a lot can go wrong at different places. And where do we usually focus? We usually are focused in these two things. Hailey, she can't buy, or she can't cook or bake, and the store that they don't have it. Most of us are not concerning ourselves with flour factories, or the truck that is delivering, or the road from Indiana to here. And we kind of care about the people who eat it, but it's not our concern. We do our best. So we have a supply, we have a career, we have the road, store it, extract it, and use it. And what can go wrong? Again, we mostly emphasize on these. I don't have money to buy it. I don't have time to buy it. Or there are very few bags left, and another neighbor just bought them. So it's short supply and storage and high demand. But any of them can go wrong. You can have shortage. You just don't have enough to produce. And we have national shortage of saline. And this is 2019. So things can happen. We don't have a truck. And I mean, we live in US and there's no good union for them. But in France, they go on a scheduled, and then there's blocked road. Or it's not blocked, but they're doing some work road and it's narrowed, and so there's traffic. It's working, but it's very slow. But again, we talked about this. And then the important thing is final outcome, if any of them doesn't work, is the same. You have angry guests that become hungry, and grandma can really die, with her fragile body. So how does it work for brain and oxidative metabolism in the brain? So brain needs oxygen. So heart is the pump here. It transports the oxygen that's in the air or ventilator and send it to blood supply. And the vehicle here, the truck here, is the O2 that is carried in both by hemoglobin or dissolved. So this is an important factor here, because each gram of hemoglobin can carry 1.34 milliliters of oxygen. The dissolved oxygen is also part of it, but it's proportional to PaO2, what we measure in ABGs. But look at this equation. If you increase your hemoglobin, if you double your hemoglobin, you essentially double the capacity of carrying oxygen. Doubling hemoglobin is having 2 trucks on the road, okay? But increasing PaO2 is adding that small partition on top of the truck. They may advertise it very high. When you go to U-Haul versus budget, they say that our trucks are better. They have that part above the driver head, and that's just so much. It is 0.003. So for an 18-wheeler, it's nothing. But if you double the number of trucks, that's a lot. Also, O2 saturation is good. It means that if you have a truck, fill that truck. Okay? If you have empty trucks, it's not going to work. So that's important. So we have to make sure always that we fill our trucks to the maximum capacity, and that's 100%. So our O2 sat should be 100%. You should have enough trucks. If a truck doesn't work, add enough truck. And we can increase PaO2, but that compartment is not going to carry a lot of oxygen. Then the important part is going back to our analogy. Brain has a very low intrinsic store. Brain is that gas station store that has 2 bags of flour in it. And it easily get, if the demand is high, which actually is very high for brain, it will easily be used. And the demand is high because brain is 2 to 5% of mammal's body weight, but it uses 25% of the oxygen and energy of the body. So something that is less than 5% of your body uses a quarter of the energy, and it doesn't keep anything in place. So it is when she has a lot of guests that are very hungry in a small rural area with only 2 bags of flour in that store. And all we talked about is actually the first part. So the store, the truck, the road, and the storage. But then when it arrives there, she still has to go and get it. If you don't get out of your house, there's no flour. That's important. We sometimes miss that part, but you have to go out and get that and bring it in. And then you have to use it. That's another part. And we can work on usage. So we can invite less guests or ask grandma very kindly that go sleep. You don't need to eat now. Let the kids eat. Let the kids eat first. So put grandma to sleep or suppression. Let the kids that are very playful and high demanding to use the oxygen first. And at the end, usually we know that we have a lot of leftover on the table. What is the important problem here? If I'm an external observer that is invited after the party to Haley's house, which is usually the case, we are not invited to the party, what is my way of understanding how much food was there and how they used it? Really leftover. I don't know about the flour factory. I don't know about trucks. I don't know about roads. I don't know about the store. I don't know about hair and baking. I don't know if people were hungry or not. I see a lot. If I see a lot of leftover, is it correct to interpret it that there was a lot of food? Maybe, maybe not, because maybe they didn't eat. Maybe they hated it. Maybe it was not usable to them. If there's very little left, does it mean that there was not enough food? No, maybe it was delicious. Maybe they needed it. Maybe there were so many hungry teenagers. So now going back to our truck. So here we have the heart pumping blood into the bloodstream, going to the brain that has very low supply and low storage capacity and high demand. You extract it and use it, and it causes some function. Okay? What can go wrong? We're talking about oxygen, and shortage of that is hypoxia. But hypoxia is a relative term. It's a demand and it's a supply-demand issue. It means that the oxygenation to the tissue does not meet the metabolism requirement of it. You may generate or produce and transfer enough, but you may use a lot. Or you don't generate enough. We usually think about the supply part of it in hypoxia, but if go back to example, a lot of our problem is usually demand. Most of our problems are store and after that, not road and before that. But if you want to think about it, you can look at these types. Most of what we call ischemia relevant to hypoxia is what is called macrovascular. That means here. That means that the heart is not pumping it. Or there is a blockage on the road. Or there's a vasospasm. All of that goes to this CBF part. Okay? The next one is microvascular. We know about it, but we don't pay attention as much to it. And that is, if you have edema, the oxygen cannot diffuse through this membrane. It's if the road from her home to the store is closed. Okay? We always think about the road from the factory to the store, but there is also some passage from her home to the store. Maybe she can pass that. That's also important. And then you have cytopathic. We don't all really think about it much, but it's possible that you can't use it. You don't have other devices to use it. Just having flour doesn't mean that you can bake a tart, right? You need other stuff. And we don't think about it, but if go back to example, it's as important. If someone tells you, I want to make a tart, what I need, do you only answer flour? No, of course, other stuff are needed. And you maybe take it for granted that she understands the basics of baking. And then it's anemia, which means that you have enough to send with it, because if you have empty roads and empty truck, doesn't matter. You should have filled truck with it. And then hypoxia at the end. So in 70s, there were a lot of clinical studies, and they found that if the flow of blood, cerebral blood flow, is low, for example, after traumatic brain injury or delayed cerebral ischemia, vasospasms, no, it causes bad outcomes. And so they found that, but this was not about long-term mortality or benefits. It was short-term. They found that people who are hypoxic do worse. That has been known for some time, really. Recent studies actually indicated that the alternative mechanism, the ones that we just talked about, are as important. So you may have edema and you cannot transfer oxygen across the membrane. You can have uncoupling. The mitochondria don't use it. You don't have the mixer. It can be a shunt, and the transit time goes up. That's the blockage at the home, passage to the store. And you can, the other factor that is important is oxygen extraction. Because what happens if you are short on something and you want to cook or bake something? You use the last, inch of it that is left in your back. That's the same thing that brain does. If it needs oxygen and doesn't have it, just gets more oxygen out of the blood. Okay, so going back to our example, what can go wrong? Again, you usually focus on these two, and even at bedside, we usually focus at these two, but here a lot can go wrong too. You can have low cardiac output. I mean it in a relative term. Just cardiac output does not meet the demand. And you can have low oxygen or PaO2, low hemoglobin or PaO2. You can have occlusion, the road is closed, or vasospasm is narrow, so the truck doesn't reach there. Or your supply, that is very low, your storage is very low in the brain, but you start using it a lot by seizure, by fever, by shivering, and or you have edema, you cannot get the oxygen, or for example, you have a metabolic failure, you are on some medications, high dose of propofol, that they cannot use as oxygen. And at the end, there is this function, ischemia, and grandma dies. And why grandma dies? Because she's more susceptible to dying. Okay? The next important factor I think that we need to really take care about monitoring and the tools that we have, and I think PbO2 at best is a toy, is what is assumption? Assumption, it's a definition from a dictionary, from Webster. It's a thing that is accepted as true as certain to happen without proof. If with proof, that's a fact. But assumption is that you accept this thing is true and it's going to happen, but you don't have a proof for it. And that's the most important thing. We assume a lot of things and we can go wrong a lot. You remember the truck example in biological and clinical processes is much more complicated. I'm sure you understood that we simplified that truck example. So usually A goes to B, B goes to C, and C goes to D. And it's important when we start intervening, because anything goes wrong at the previous stage, you can diverge into more and more issues and problems. What can go wrong? A lot. So it depends on what you're thinking, and going back to what we talked first, what are you monitoring? Is it a physiological, pathological entity or a surrogate for it? How accurate do you monitor it? Can you change it? And if you change it, does it change the outcome? Example of blood pressure as a long-term preventive measure is different. Blood pressure is tightly regulated in our body. We know that. We also know that high blood pressure causes organ injury in long term and short term. That is also true to a large extent. So we make this assumption that we should monitor blood pressure, and if it is high, treat it to prevent organ injury. To a large extent, it works. It decreases rate of a stroke and myocardial infarction and kidney injury and all those stuff. Not completely, because part of it is assumption. But let's go to our PbO2 example. Cells need oxygen. That is true. Lack of oxygen disrupts cell function. There is a lot else that can also cause cell destruction. So if you see that cell is not working, doesn't mean that you don't have enough oxygen. You may not have enough oxygen. You may not have a lot of other stuff in place. So you assume that you should monitor oxygen to predict cell function. Well, you can monitor oxygen, actually not at bedside very well, but to predict cell function as a surrogate, that's a different thing. If you monitor oxygen for the sake of oxygen, it's one thing. If you monitor oxygen to predict cell function, that's a surrogate that we don't know about, because cell function depends on a lot of stuff, not only oxygen. Oxygen is a part of it. And then we say that, okay, so if we correct oxygen, the function will improve. As far as we know, there is no proof for that so far. Okay. So what are the assumptions here? So brain hypoxia can cause secondary brain damage. That is pretty much true. We know that. So we use modalities, and we know that something like CPP or ICP are not surrogate for brain oxygen. They are for blood pressure and pressure. So we monitor brain tissue oxygenation, and the best we can say is that it may improve outcome. So I think if we are going to use this toy based on all what we talked about in the past 25 minutes, is that the brain oxygen monitor is not intended to be used alone, because it's not the only thing, and it's not even an accurate thing, and it's not a reliable thing, and it doesn't change the outcome necessarily. So use it as another toy. What are the ways to measure brain oxygenation? So some of you may remember jugular venous bulb oximetry. It was a technology of 90s. In 2000, it started disappearing really. Then we have direct brain tissue oxygenation measurement. PbO2 measurement by Romedic is one of them. We have near-infrared spectroscopy. In other units, they use it sometimes. Despite having been used for more than 2 decades, the data on its implications and prognostication is extremely rare. And then we have PET. It's still the gold standard. As far as I know, only 2 ICUs in the ward can use PET at bedside, because it has an isotope that lasts for 5 minutes. So you need a reactor next door to you. We don't have it. So what is PbTO2? What is you have that dramatic, you put it there, it gives you a number. What is that number? Well, it's still unclear. But what you can say is that it measures the pool of oxygen that is accumulated in the tissue, hence leftover food on the table. That is what PbO2 is. And after the fact, external observer looking at the leftover food, it doesn't really say directly anything about the supply, use, hunger, quality, none of them. It's of course influenced by delivery of love. So yeah, of course, if there is no food to begin with, there is no leftover, right? Also consumption, but consumption it's a weird thing, because if they don't eat anything, there is a lot of leftover. If they eat everything, the leftover is less, but it's not. But you don't know. I mean, just leftover is not the best measure of consumption, because one other factor is how many people ate and how much. Okay, so if you look at this is blood coming in, it diffuses from the arterial side to the venous side. It's being used in the brain, and there's some left over, and your probe is here, and it's measuring this one. So very indirect way to look at something extremely complex. So the PET studies shows that the amount of it correlate inversely with oxygen extraction, which we understand that if you have less food, you don't leave anything on your plate. You finish everything, right? That we understand. What PbO2 is not, it's not a surrogate of cerebral blood flow. They may correlate, actually sometimes inversely, but they're two different things. They're really different stuff with each other. So saying that PbO2 is a good surrogate for CBF, it's saying that leftover food on the table is a good measure of the rapidity of trucks flow, on the road. They're very different things from each other. Also, they found that there's no improvement in metabolism of oxygen after giving hypoxia, which we already learned that because there was that compartment, overhead compartment, very little capacity. Okay, this is the same thing here. And you see, for example, cerebral blood flow and PbO2 are correlating, but they're not the same thing. Okay, how do we measure it? Two common methods available. One of them is like two electrodes in an electrolyte. If you have more oxygen, it diffuses more. It causes more, voltage difference between the anode and cathode, and it causes, there's a higher currency. So that's one way. That's what we use. It's Rhomatic, and Lycox use the same technology. What's important here? Temperature, because higher temperature is more diffusion. So these devices either need to be calibrated or self-calibrate by design, like Rhomatic. And there are devices that work with fluorescent. More oxygen changes the color. We don't use that. Some ICUs use that device. The advantage of this one is that actually it does not use the oxygen because our own devices consume oxygen to measure it. So there's some factor that is difficult to predict that it may affect your measurement because you're measuring something that you used to measure. And how can we use it? For a lot of stuff. For example, many times we increase CPP. Usually, we go up by 5, 10, 15, something like that. There's no rule behind that. So you can use this device to a target and increase CPP using your PbO2. You may want to know what is the optimal ICP control. This patient may easily tolerate 25 because oxygenation is good, or you can go to 15. Or you may use it for transfusion. The data for transfusion is usually from larger studies saying that people with 7 did as good as 10, but not this patient. So you can use it. And also to adjust mechanical ventilation in complex patient. You can use it to guide fluid therapy, sedation, burst suppression, normothermia. All of them are studied in like small series, retrospective, so not a lot of data. Indications, you can use it for diffuse and focal brain injuries. In most of the time, people who have low level of consciousness. So severe TBI, high-grade subarachnoid, malignant stroke, or massive cerebral edema, for example, with hemorrhage or tumor or meningitis. Where do we put the probe? Well, it depends on the process. In traumatic brain injury, that something is diffuse, many times they go to a more silent part of the brain, right frontal lobe. If there is an area in danger, you try to be close to it, not inside the dead tissue, but close to it. So for example, for subarachnoid, if you have an idea where you may have a high risk of vasospasm, usually you don't, you play close to that. And if you have an infarct, you have to make sure it's not inside the infarct because that's a dead tissue and oxygenation doesn't matter. So how do you verify that? Well, usually you have all noted it takes, depending on the device, 30 minutes to 2 hours to self-calibrate. Before that, the numbers are not reliable. We usually do a transient FI to 100%, 5 minutes, and see if there is a significant increase. And the response, if the perfusion is not very good, is not going to be reliable. And some places do it once. Most places do one oxygen challenge when they place the monitor. Some places, especially places that use it for TBI per protocol, they do it every day to make sure it's still working as much. It's easy, doesn't cost much, and it's probably a reasonable thing to do. Doing CT scan is not a standard, but especially if it's not responding, maybe it's a good way to check if it's positioned well or it's not associated with any complications. About the safety of it, it more or less carries the same rate of complications as a bolt. It's a small device, risk of infection is really very low, and it keeps working for a good amount of time, for about 2 weeks or so. So complications are not really a big issue here. Of course, someone anticoagulated is high risk, but it's not as much as an EVD. What are the normal values? I'm sure you now know the numbers. It gives a milliliter of mercury. You know the number for CMRO2. So normal values probably are in 20s to 30s for human beings. Well, we don't have volunteers for that, but they do functional neurosurgery and things like that. So the numbers are probably in high 20s, mid 30s most of the time. But they found some threshold for hypoxia. If it is 15 to 25, probably moderate, and brain have other ways to compensate. For example, oxygen extraction increase. They have critical, which is less than 15, and less than 10 is associated with cell death, but not death of the brain, just cell death. And more than 50 is high. We don't want those numbers. How can we influence it? Again, go back to this picture. So you have to bring the blood. It has to diffuse from arterial side to the venous side. You use it, and there is a leftover. Okay. So we have flow, diffusion, and consumption of it. So we can change any of them. And we already talked about the carrying capacity. It correlates with oxygen saturation and hemoglobin, all those linearly, and very little of that overhead compartment, and then use of it. And how can we change cerebral blood flow? One way is increasing CPP. Increased CPP cerebral blood flow will go up. However, this important factor, that's the diameter of the vessel to the power of 4. So if you have vasospasm, that's not going to work very well. It doesn't matter. So if you have a tiny, tiny hose, if you put your thumb on front of it, yeah, the pressure will go up, but there's not so much to begin with. It's very tiny. And then length, here we can change the length of arteries, but the length I'm talking about is if you have edema here and increases the length. I'm talking about the length from the passage from home to the store. Okay? And then there's viscosity. Very viscous blood does not carry as much. So there are ways we can adjust them. Most importantly, again, we talked about it. You can ask grandma to go to sleep. Decrease the agitation, seizure, temperature, and shivering. And again, let's assume that you have a normal hemoglobin around 10, cardiac output is normal, about 5, and O2 saturation is 100%. Your FiO2 is 40%. Your PaO2 will be 200, so oxygen carrying capacity is 50.04, okay? You increase it to 100%, it goes to 50.1. That's the overhead compartment. It doesn't carry too much. It gives you a high number. Why? Because there will be a lot of leftover that no one used. It doesn't imply anything. So don't go with that number. So you can use FiO2 challenge, because if you bring a lot of food and throw it on the table, there will be a lot of leftover, but doesn't mean good consumption. And what we are worried about is consumption here. So there are many studies. They found that low PbO2 correlate with bad outcomes. As far as I know, there is no high-quality study that says that if you improve it, you will have better outcomes. So currently, there is no guideline or consensus on this. Okay, all we know is low oxygen is bad. Increasing oxygen does not necessarily mean good outcome. Okay, therefore, most studies and people use a stepwise tiered approach to it. They probably start with less aggressive to more aggressive, and also try to fix things that have double beneficial effect. For example, if you have probably all noted, if you decrease ICP, usually your PbO2 will go up too, and you have to decrease ICP anyway. So work towards that first, and then go to the other thing. And O2 challenge is usually the first step. So let's talk about just one study, because that's the only randomized clinical trial we have. It was in traumatic brain injury patients, about 120 patients, phase 2 in ICUs. And they used, the way they designed is that people all have ICP monitors and all have PbO2 monitors. They blinded them with a physical barrier, so they covered the PbO2 in half of them and the other one. So physicians had data for ICP and PbO2 for half of the people, had the data for ICP only for the other half. However, the data for oxygen was being collected. They could look at it later. And they wanted to see the safety of it. So they divided the treatments into 4 groups. a 2x2 table based on ICP and PbO2. Normal, abnormal, normal, abnormal. So if both ICP and PbO2 are normal, of course you don't do anything. If only ICP is high, you treat ICP. If only PbO2 is low, you only treat PbO2, and if both, it's a combination of both. So this is the schedule we have. It's a bit complex. We may not always necessarily go down the same route and the same order they had, but it's a study, so they protocolized it. You can see it's complicated. There are a lot of factors in it, and a lot of it is left to discretion of the providers at bedside. So the outcomes, if you compare the ICP only with ICP and oxygenation group, the proportion of time with low oxygen was significantly higher with ICP. So if you don't use PbO2, you don't do things that you do, and you will have a high amount of time with low oxygen that you're detecting. Again, that's not oxygen consumption of the brain that's left over. So we have a lot of leftover. The depth of it was also deeper. The amount of hypoxia they were detecting was more. But if you look at the ICP measures, they were equal because both of them had ICP monitors. So it seems that they did a good job in managing ICP in both groups. Also, when they had the PbO2 number, they were able to change it. So now we know we are measuring a surrogate. We know that we are measuring it accurately and reliably, and we know that we can change it. What we don't know if it changes the outcome. It was a phase 2 study, so it was designed with a low number of patients for safety. It shows a tendency towards improvement. As you go, this sort of worse outcome. So as you go up, you see that people are doing better. Okay, but this study was not definitive, and they are designing Boost 3. So what we do here, this is what I worked with Lathe to generate. I think it's a reasonable way to approach it at Inova, given our device, Rheumatic, and the patients we typically treat, which are subarachnoids, not TBI patients. But this is not a guideline. This is what I made for some friends, and Lathe commented, and I edited it. So you place the Rheumatic. The first question is your ICP reading by Rheumatic accurate? Because it may not necessarily be the same as your EVD that you have, but it should correlate at least with that. If it is not, you may want to go to bypass and go to CT scan, see what's wrong with that. And ICP measurement starts as soon as you place it, right? The second one is that so you do CT. If the ICP measurement is correlating, wait a couple hours, do FiO2 challenge. Does it go up with 100% oxygen? If it does not, get a CT scan. If it does, so your probe is in place and it's working, okay? So if you bring a lot of flour to store, you will have some left over, okay? And now look at the ICP. If your ICP is high, ICP is high, I think the best thing is to start managing ICP, because not only you need to do that anyway, but also it will improve your PbO2, and do it first. Also, ICP management is more or less a standard of care. So you can't say that I'm not doing that because I have another thing that I need to worry about. That's the standard of care you have to deal with. But if your ICP is normal and your PbO2 is low, you have two strategies. One is to bring more oxygen to the brain, to increase delivery of the oxygen. So here we are talking about everything before reaching your home, okay? Or decrease the consumption, change the habit of eating at your home, okay? How can you change that? Well, I think we should consider continuous EEG at this time, because that gives us a clue of how much they're eating. And you can either increase sedation. So for example, you can add ketamine here, or propofol or whatever. Or you can do paralytics and hypothermia, because hypothermia also decreases the amount of consumption. So one of those things, or a combination of them many times. And you can increase the delivery of oxygen. There are two ways to do that. One of them is increase the oxygen carrying capacity, okay? The ways to do that is really the only way we have at bedside is increase hemoglobin. Just have more trucks on the road. So and you can transfuse to a goal, let's say 10, for example. We don't really have any good data for any disease that hemoglobin more than 10 is required, so that will be something that we don't want to go there. And increased CBF is another way. So what are the ways to do that? Well, one of them is cause vasodilation, for example, because you remember that was the radius of the diameter of the vessel to the power of 4. So you can do that. And then the other thing is increase CPP. So you can increase your MAP here by pressors, or you can increase the cardiac output. Some treatments, for example, like transfusion, it will also increase your CPP. Or ketamine will also increase CPP and also increase sedation. So there's a combination you can do. Again, to review it briefly, I think you check if the ICP is correlating. If not, do a CT. If it is, do oxygen challenge. If it's not working, do a CT. If it is, check the ICP. If it is high, treat ICP. If it is low, either increase the delivery or decrease the use of it. To decrease the use of it, with a guide of EEG, increase sedation or induce hypothermia. To increase delivery of oxygen, either increase capacity of delivering by transfusion or increase cerebral blood flow by CPP or MAP or cardiac output. And don't forget about vasodilation. I think, again, this is for subarachnoid patient. Usually vasospasm is not a big problem in traumatic patients that we know. So let's look at 3 cases. You have a 55-year-old woman, subarachnoid high grade. PbO2 is placed on post-bleed day 5. 3 hours after placement, the number is 4. What do you do next? Anyone? Exactly. You do a FiO2 challenge for 5 minutes. You just placed it and you don't know if it's working or not. Okay. You place the probe, FiO2 challenge work. Your CPP is 75. Heart rate is 125. Respiratory rate of 37. FiO2 40%. O2 sat 95. There is poor ventilator synchrony for the patient. PbO2 is now between 12 and 18, but it goes up to 28 if you do 5 minutes of 100% oxygen. What do you do next? Yeah, because here you don't need the CT. You already done one. You don't need the CT. I think it's too early to do this. This wouldn't do anything because your ICP problem is good. So you just increase the sedation. And you want to just cause synchrony, not too much. Okay. Your PbO2 is 14. It goes up to 26 after 5 minutes. So it's working. CPP is 75. ICP is normal 18. Hemoglobin is 10.2. What do you do next? Well, I think it's a good example, shows that this is one of the toys that make you do a lot of stuff. And that's why we should be cautious about it, because you can do a lot of these things. Well, you don't need to do the CT at this time, but you can increase MAP from baseline. Probably that will be the most common response. But you can bring ICP. I understand it's 18. It's not wrong to bring it down, and it will help. And you can increase sedation further because that's the demand. So it will work if you do that. You can transfuse 1 unit, probably not because hemoglobin is 10.2, but that's something that you might want to, but it's very close to 10, you may want to keep checking it, and if it goes below that, you may want to consider it. And you can start milrinone, that also helps. So I think that because that we don't know what exactly we are measuring, how accurate it is, and will it change the outcomes, but you can do a lot of the stuff, and they're not harmless by themselves. Induce hypertension, administering dangerous medications, extra transfusion, and inotropes can be harmful in the patient. So we have to be very careful about that. Okay, I'm 45 minutes done. Any questions? Yes, ma'am.
One of your slides you mentioned pleosis around the probe affecting the reading or affecting the accuracy. Or about how long would you expect that to happen, and at what point do you say I don't trust these readings?
I think if you have done the calibration phase, the 2 hours, and the probe readings, and your FiO2 challenge works, if the probe readings are not accurate, then they're not going to be. You can get a CT scan. I deleted that aside. If it's inside the infarct, you have 2 things. Either you always get low, or if you give oxygen, you have like a luxury perfusion. So that probe is not going to work. We had a patient recently, was Beth Tenjing, right? That she was close to an edema area. At some point, I think the probe became more useful. In the beginning, it was very close to an edema around infarct. Then edema went down, and probe was having a more realistic number. But I think if you do the challenge within minutes, you don't need to wait days or think that it's got unimproved. It's a reliable trend, and it's an accurate number. It's just a surrogate for what we don't know what it is. But the number is right. And how high you mean by high? Like 200 or?
No, my question was what's the gliosis over time?
Oh, that's one. That's That's experimental. It develops over weeks. So I think the data we have is at least for 2 weeks. People have been using it without issues. I have not. We have not used it longer than that. But I haven't heard from anyone that concern of gliosis making it inaccurate over time. And have you ever had any probe that was long enough there that we think it was not working anymore?
The
No.
longest one we used, I would say, because we started like with day 15 patient, and then we monitored to day 25. And
Yeah.
that patient happened to be a late presentation on the skin, giving us the result.
Yeah. And then
We do see in the initial evaluation period, if you want to set 2 hours, but we do see it's longer sometimes.
longer.
Yeah, I feel like it's longer.
Yeah. But we don't. We I don't. There are very few situations that I can think we need a PbO2 monitor more than 2 weeks. So we haven't had we haven't come across that problem. But I can imagine if you use it, for example, for ECMO patients that are on list for transplantation, it can be prolonged. But once I searched and I didn't find any real any data for ECMO, so I don't know if what will happen to them. Any other questions? No. Okay. So I think I printed, Haley printed the protocol for you, but please remember this picture because that's more explaining. Yeah. Well.